And welcome back to the part 4 of our series on the approach to chronic dyspnea. So today we'll be discussing the first part of cardiac examination. I've divided it into three separate parts. First we'll be discussing the pulse, apex and JVP. In the second part we'll go over to the S1, S2, S3 and S4 sounds as well as added sounds, and in a separate series on probably on palpitations and an approach to valvular heart disease, we'll be discussing auscultation of murmurs. So going right into it, these will be the three topics that I'll discuss in this particular video, that is the peripheral pulse, apex beat and jugular venous pulse. So starting with the peripheral pulse. The peripheral pulse may be normal, okay. It may show an abnormal waveform, it may show abnormal rhythm, and there may be something called pulsus paradoxus. Now actually this is neither a pulse finding nor is it paradoxical, so we'll get to that. So what is the normal pulse? So the normal pulse waveform is this. So what I've shown here is actually the waveform that you would get if you were to put a highly sensitive mechanical transducer on, say, a peripheral artery and then see the waveforms. Now when you palpate your actual radial pulse or your carotid pulse, this is not the waveform that you get a single peak, because the second peak is actually not perceptible to normal human touch, but variations in this waveform are what result in abnormal pulse waveform. So we'll have to understand this waveform at a detailed level. Okay, so as you can see, the pulse waveform has to be understood in the context of the cardiac cycle. So here this is the S1 sound. So S1 sound represents closing of the atrioventricular valve, that is the AV valve. On the left side the mitral valve and on the right side the tricuspid valve. So once it closes, we have isovolumetric contraction, okay, or the isovolumic contraction. Now when that happens, please remember this is not the fluid column moving, okay. There is a mechanical wave being conducted along the wall of the aorta and then the peripheral vessel, right till where you're palpating the peripheral vessel. So even though there is no ejection of blood here, there is a mechanical wave produced, and that does get conducted. Okay, so this wave is what we call the percussion wave. Now obviously the percussion wave is dependent on the contractility of the ventricle. Okay, now once the isovolumic contraction phase gets over, the aortic valve or the pulmonic valve opens up and then blood is ejected into the aorta and the pulmonary artery respectively. Now as this happens, the aorta and or the pulmonary artery, in this case the aorta because we're talking about peripheral pulse, the aorta dilates and then comes back. So because of its own elastance, there is a mechanical wave produced in the aorta. Okay, that wave is due to distension of the aortic wall. So that is what we call the tidal wave. Then as the blood goes into the periphery, what is known as aortic runoff. Okay, so as there is aortic runoff, this is flow from the aorta into peripheral tissue. So the pressure gradient there would be the pressure within the aorta divide minus the pressure that is the pressure in the tissue, okay, divided by the resistance. Now see, tissue pressures on average are always constant, and aortic pressure has gone from its normal 80 to 120 and then it's coming back to 80 during systole. Okay, so it is the resistance or the peripheral vascular resistance that determines this aortic runoff. Okay, this is what we call the tidal wave, and that is what results in a descent of the tidal wave. So as you can see, the descent of the tidal wave passes through the S2 sound, that is the closure of the aortic valve. Okay, now the thing is, because there is the compliance of the aorta and the large vessels, which what are also called the Wynn-Kessel vessels, is significantly more than those of the peripheral blood vessels, as long as as long as normal peripheral vascular resistance is maintained, there is usually a reflected wave that comes back from the peripheral vessels. Okay, so this is your aorta or any other ventricular vessel which is continuing into a smaller but much more muscular and much more thick vessel. Okay, so a wave traveling along the aorta actually won't be able to, pardon me. So this is the aorta, and this is extending into a much thicker vessel with a much thicker vessel wall. Now a wave that is traveling along the aorta will reach this point, and some of it will get conducted, but because the compliance of the distal vessel is so less, part of it will also be reflected back. Okay, and that reflected wave is what we call the dicrotic wave. Okay, this is the dicrotic wave. Now the more the peripheral resistance, therefore the thicker the peripheral vessel, and the thicker the peripheral vessel, the higher the amplitude of the wave that is reflected back. But as you can see, the tidal wave is actually the most dominant wave in a normal pulse waveform. So normally when you palpate a peripheral pulse, say the radial pulse, or when you're looking at waveform and volume, we usually look at the carotid pulse. There you will only get one palpable wave. That is due to limits of our own ability to perceive two separate waves separated in time, such a short period of time. Okay. Now there is also a dip in between. This is known as the dicrotic notch. Okay. So this happens because of what? It happens because of a downward movement of the aortic valve, because blood is moving from the aortic lumen back into the ventricle once the systole is over. Now when that happens, blood doesn't know that it is just supposed to go to the periphery. It follows the pressure gradient. So as the ventricular pressures have fallen down, aortic pressures are more, and that causes reversal of the flow, that is the blood column reversing its flow towards the ventricle. The valve closes in a normal person and therefore prevents the blood flow, but the valve is pushed. Okay, so that pushing back of the valve is what creates this dip. Okay, so I hope it is clear the normal components of a normal pulse waveform. Now, what about abnormalities that can develop from this? So one is what we call a hyperkinetic pulse. Okay, so in a hyperkinetic pulse, what happens is the person's peripheral vascular resistance is decreased. Okay, so because of that, two things happen. One is that the venous return is increasing. The second thing is that the dicrotic wave has decreased significantly in amplitude. So that is what you can see. Because the dicrotic wave has decreased, this wave has come down and it is decreased in amplitude. So this is the reflected wave that is reflected based on the compliance of the distal vessels. Now the distal vessels, because they have dilated here, are less compliant, therefore less of that wave gets reflected back. Okay. Now since venous return is increased because of the Frank-Starling mechanism, which we will discuss subsequently also, the exact reason for this Frank-Starling mechanism. Either way, the Frank-Starling mechanism is that if you increase the amount of volume within the ventricle, either ventricle, at the end of diastole, the force of contraction increases. Okay, so since venous return is increased, the force of contraction increases, and we discussed that the percussion wave is due to the force of contraction. Okay, and since there is more blood that has to be ejected, the tidal wave is also increased. So you have an increase in the percussion wave, the tidal wave. They are very close to each other, so are not felt equally, but there is a rapid fall in the wave. Then that is a very prominent descent is there in the of the tidal wave, and the dicrotic wave is essentially decreased in size. Okay, so this feels like a rapidly rising and falling pulse. Okay, so this is something that we need to understand, is what we call a hyperkinetic pulse. So this happens in very specific scenarios when there is a significant reduction in the peripheral vascular resistance. So they are when a patient has thiamine deficiency, there is anemia, there are situations in the early stages of Paget's disease, if there's an AV fistula, or if there is any reason for decreased sympathetic tone, that is what we would call distributive shock. Okay, Now, in some normal physiological conditions also this happens. So in pregnancy, because of progesterone levels being very high, there is vasodilatation and decreased vascular tone. When you have anxiety, it is reported, but typically in anxiety you have the reverse. Okay. And then in exercise. Now exercise is a very important thing, because exercise, this is actually when you can feel like a hyperkinetic pulse most commonly in a normal person, somebody who is completely normal. Okay, fine. Now we come to the next pulse, that is the pulses parvus et tardus. Now in Latin this means, parvus means small and tardus means slow. Okay, so what is causing the pulse to become small and slow, and what part of our waveform is actually becoming small and slow? So it is actually the tidal wave that is getting smaller and the peak of the wave is getting delayed. So what could be the reason for that? See, tidal wave represents what? It represents the stroke volume. Okay, and the stroke volume is the amount of blood that the ventricle is able to pass through its outlet into the aorta. So if the outlet is small in size, then automatically the ventricle will be able to, first of all, not be able to push it out as much blood. The second thing is that the ventricle will take longer to reach its maximum velocity or the maximum flow rate. So that is why the wave actually falls downwards and the peak gets delayed. So the peak was here and it has moved here. Okay, this is what we call a pulsus parvus et tardus. And LV outlet tract obstructions basically are these two. We'll discuss later during valvular heart disease. There are others, so it could be divided into supravalvular, valvular, and infravalvular. So the prototype of valvular is aortic stenosis, and the prototype of subvalvular aortic stenosis is or LV outlet tract obstruction, particularly dynamic, is hypertrophic obstructive cardiomyopathy. So around 33% of hypertrophic cardiomyopathy cases. Now there are some situations in which you can get a false positive also. So see, if the patient has got a heart failure with reduced ejection fraction, the ejection fraction itself is low, so obviously the tidal volume will be low. Okay, and as it becomes lower in size and contractility decreases, you get the same finding. So a pulsus parvus et tardus in isolation doesn't necessarily mean that there is a LV outlet obstruction. The other thing that can happen is there could be an obstruction even more distally, that is within a distal part of the aorta or the carotids. Okay, and it would have the same effect because the afterload on the ventricle would still be increased. Okay, so those are your false positive causes of parvus et tardus. Then we have our very famous Bispherians pulse, something that causes confusion in practically any medical student I've ever met. So see, unless you understand the basal waveform, you will not understand the mechanisms behind the Bispherian pulse. So what happens here is, say you have aortic regurgitation. Okay, so when you have aortic regurgitation, the left ventricle, so when you have aortic regurgitation, the left ventricle and its outlet. Okay, now what is happening is blood goes from the aorta back into the left ventricle during diastole. Okay, so as a result, there is increased LV and diastolic volume. Now, because of Frank-Starling mechanism, LV contractility increases. Okay, so there is an increase in the stroke volume. The stroke volume is increased. So more blood is pushed into the aorta. Okay, so LV contractility is increased. So naturally, the percussion wave will increase. This is what we are seeing here. Okay, this is because LV contractility has increased. And because we are also pushing into a lot of blood into a normal or a slightly enlarged aorta, there is a functional aortic stenosis. Okay, so technically the peak of the peak of the tidal wave also gets delayed. There is an elevation in the percussion wave, and there is a delay and prominent tidal wave. So what you end up having is two pulse movements in systole. Okay, this is very important because it is the two pulse movements in systole that are causing this. Now, when you have this kind of a regurgitant flow from the aorta back into the ventricle, what you find is that the peripheral perfusion decreases. So the tissues need their metabolites and oxygen delivery. So the tissues there is local vasodilator mediated increase in the vascular compliance of vessels more distally. So as a result, the dicrotic wave also decreases in size. So you get two very prominent waves, both felt in systole. Okay. Now we come to the dicrotic pulse. So what is happening here? So here what is happening is the patient has gone into shock. So because the patient has gone into shock, venous return to the left ventricle has decreased. So because the venous return to the left ventricle has decreased, the amount of distension of the left ventricle at the end of diastole is decreased. So when the ventricle starts to contract, it ejects less blood. So there is a decrease in the stroke volume. So when the stroke volume decreases, naturally the tidal wave will fall down. Okay. Now the other thing is, because the patient is in shock, the sympathetic tone has increased. Now because the sympathetic tone has increased, naturally there will be an increase in peripheral resistance. So there's an increase in peripheral resistance. So two things are happening simultaneously. The amplitude of the tidal wave has decreased and the amplitude of the dicrotic wave has increased. So now again you feel two pulses, but this is a systolic pulse. And this pulse will be felt in diastole. So you feel two separate pulses, just like Bispherian's pulse, but one is in systole and the other is in diastole. Okay, and the cause is basically shock. Now, in patients who have an intra-aortic balloon pump, the pump can produce a pulsation during diastole. It produces two separate pulsations. So that can look like a dicrotic pulse. There are two pulsations, one in systole and diastole, but see, that is just a false positive. Okay. Now coming to abnormalities of pulse rhythm. So actually all tachyarrhythmias and bradyarrhythmias are technically abnormalities of pulse rhythm. And to analyze them, we need to actually go into the detailed analysis of tachy and bradyarrhythmias. So that is beyond the scope of the present lecture. We'll come to that in a later series. However, there are two abnormalities that are named, so I want to cover here. That is pulsus alternans and pulsus bigeminis. Okay. So what is pulsus alternans? So when there is a patient has sinus rhythm, but there are intervening ventricular premature contractions. At that point of time, the ventricular premature contraction may or may not cause a compensatory pause. But if it does, what you end up having is you have a normal pulse, then you have a pulse due to a ventricular premature contraction, and then there is a pause. And then again you have a normal pulse, there's a pulse due to a VPC, and then again a pause. So you get two pulses. Okay, now these two pulses are both in systole, but they are in two separate systoles, unlike Bispherian's pulse. Okay, so that is what we call a pulsus alternans, and it actually reflects a sinus rhythm patient having intervening VPCs that are causing a compensatory pause. So there are VPCs that might not cause a compensatory pause. We'll come to that. They're called interpolated VPCs. We'll discuss that at a later date. Now, you can also have two VPCs occurring simultaneously. Okay, so when two VPCs occur simultaneously, what happens is that you will have one large wave, then a small wave, because when there is a ventricular premature contraction, diastole has shortened. So the shortening of diastole itself will cause the second wave to become decreased in size, because what we are feeling is the tidal wave, and the tidal wave reflects the stroke volume, which in turn is dependent on LV and diastolic volume. So that is what we call a pulsus bigeminis. So these are the two named abnormalities. Both occur in heart failure. Okay, so that is your analysis of pulse. Now there is another named abnormality, that is a Faggot sign, rather unfortunately named. Now it basically refers to relative bradycardia. That is that is when the patient has fever, you expect the pulse rate to increase by 15 to 20 beats per minute from whatever is the normal baseline pulse rate for every 1 degree centigrade rise or Celsius rise from the norm. Okay, so 98.6 or whatever, depending on the time of the day, the norm. Now, when does this happen? This usually happens when there is myocarditis or there is something that is decreasing the sympathetic tone. So, myocardial infiltration by a lymphoma is a described cause. So, this is something that most people don't remember. So, this is something that I would like you to remember. Now, the other things that can cause it are a beta blocker, which would decrease the sympathetic tone, specifically beta 1 receptors would not be activated. So as a result, the heart rate would not increase sufficiently. CNS lesions, okay, because they increase vagal tone, and drug fever. Okay, so these are the four entities outside of infections that cause Faggot sign. Okay, and they can be remembered using this mnemonic that I have shown you, that is ABCD. A is a lymphoma, B is beta blocker, C is for CNS lesions, and D stands for drug fever. Now, on the other hand, these are the infections that can cause it. Okay, so I like to again, it's very specific infections, and when we go into the individual pathogenesis of these infections and the clinical features they come up with, you will realize that all of them cause some degree of either myocarditis or microvascular ischemia within the heart. So that is the mechanism. So what are they? One is viral myocarditis. Okay, particularly dengue myocarditis is actually even associated with bradyarrhythmias. Then what we don't get in India, that is yellow fever. Then among bacterial infections, the diseases that cause them are all the diseases that actually modulate the immune system. Okay, so it is Salmonella, Brucella, Coxiella, and endotheliotropic, that is Rickettsia, and then Legionella, Francisella tularensis, and diphtheria. So diphtheria causes a toxin-mediated myocarditis, which is different from the other entities in this list. But diphtheria produces a toxin. Okay, the other entities are actually causing direct myocarditis. So okay, moving on. So we'll now be discussing pulsus paradoxus. Now, the name itself is a misnomer. It is not a pulse sign, and it is also not a paradox. So what is it? So actually, it is an exaggerated fall in the systolic blood pressure when a person inspires. Now, during inspiration, what happens is there is negative pressure within the chest wall. We've discussed this while discussing lung examination and PFT analysis. So because of that, see, blood is also going to the entry of blood into the chest cavity will also increase. Now, blood will therefore enter into the right atrium and then go into the right ventricle, increasing the right ventricular stroke volume. However, both the pulmonary veins, the left atrium, and the left ventricle, all three structures are actually within the chest cavity. So even though that there is negative pressure within the chest cavity is technically, all three structures have the same amount of negative pressure. Okay, so inspiration increases venous return to the right side of the heart, not to the left side of the heart. In fact, because there is increased venous return to the right side of the heart, there can actually be a shift of the interventricular septum towards the left ventricle, decreasing the internal diameter of the left ventricle, resulting in a decrease in stroke volume. Now, normally this doesn't happen, the second process that I discussed. So normally the gap in the reduction in the stroke volume from the left side of the heart is actually very minimal. It is less than 10 millimeters of mercury during inspiration. However, if this normal process gets exaggerated, then we get what is called what we call the pulsus paradoxus. But see, this is not a pulse finding. We check it while checking blood pressure. Okay, and it is not paradoxical. It is actually an exaggeration of the norm. So what might cause this exaggeration of the normal? So there are two situations in which this can happen. One is that the venous return is increasing as much as it increases normally. Okay, so respiratory effort is normal. There's nothing, no exaggerated respiratory effort. However, there is a restriction to inflow into the heart. There is something that is preventing the heart from dilating throughout diastole. So because of that, both the right ventricle and left ventricle are prevented from dilating. So pressures rise faster, and because of that, the interventricular septum is pushed more into the left ventricle. Usually the interventricular septum is quite thick, so pressures within the right ventricle cannot push it that side. But when this happens, when there is a problem in ventricular filling throughout diastole, the pressure is right enough to push the interventricular septum into the left ventricle. As a result, the right ventricular stroke volume increases and the left-sided stroke volume decreases, resulting in a gap, a fall in the left-sided stroke volume, and therefore a fall in the systolic blood pressure, which is directly related to the stroke volume, by more than 10 millimeters of mercury. Okay, so that is all of these causes. Now, the other cause is when the venous return is actually more than the right ventricle can handle. So that happens when a person is breathing in putting in a lot of respiratory effort. So this happens with acute exacerbations of asthma and COPD, and actually this is, epidemiologically speaking, the most common cause of a pulsus paradoxus. Okay, now, and other reasons can be as follows. You can have a pulmonary embolism. So pulmonary embolism increases the peripheral resistance within the pulmonary vasculature, and because it increases the peripheral resistance in the pulmonary vasculature, there is back pressure into the right ventricle, and the right ventricular pressure increases, which again shifts the interventricular septum to the other side. Okay, now the other thing that can happen is hypovolemia can cause tachypnea. So as we discussed, anything that causes tachypnea will again increase the amount of venous return being pulled into the right ventricle, and as such, when you are in shock, your left ventricular output is low. That is the literal definition of shock. So that is when you have, that is another reason when you can have it. And it has also been reported to happen in obesity and superior vena cava syndrome. Okay, so changing track, the next thing that we'll be discussing is the apex beat. So the apex beat is something that we need to discuss a little bit in detail. So we have the normal apex beat, we have abnormalities of the character of apex beat, we have abnormalities of location and or size of apex beat, and we'll start with what a normal apex beat is. Now, there is something very interesting that needs to be discussed about the apex beat. Exactly what is it? So it's actually a representation of the law of conservation of energy in the form of the law of conservation of momentum. Okay, so what is that state? That state, law of conservation of energy, we've discussed previously. So the law of energy, when applied to momentum, see, if there is no external work being done on a system, okay, the center of mass of that system cannot shift, because work done is equal to force times displacement, and if the work done is zero, okay, then displacement has to be zero, which is the multiplication. Okay, so the center of mass of the system cannot move. Now the heart is a closed system. The heart is itself causing the movement. So then when there is contraction of the left ventricle, what will happen is that blood goes out of the left ventricle into the aorta. So there is a movement of the blood column, and a shift in the center of mass would occur if there was no equal and opposite movement in the opposite direction. So this is the equal and opposite movement in the opposite direction. So that equal and opposite movement actually is felt as a push on the chest wall, and that is what we call the apex beat. Okay, so the normal apex beat is located in the fifth left intercostal space and occupies an area that is less than 2.5 centimeters square, a small coin. Okay, so if you're in India, a 2 rupee coin or something like that. Okay, so that is your normal apex beat. So what do I mean by abnormalities of apex character? So normally the apex lifts your fingers, the palpating fingers, a little bit, but up to the level of the surrounding ribs. And if you apply a little bit more pressure, it gets obliterated. It cannot lift your finger anymore. So when you have this is the normal character of the apex beat. So when you have abnormal character, there is an increase, there is something that is changing in the type of change in momentum that is occurring. Okay, so what is the first thing? The first thing is what we call a hyperdynamic apex. So in a hyperdynamic apex, this happens in high cardiac output states, where, as we've already discussed, we also get a hyperkinetic pulse. Okay, so why was that? Because the stroke volume was increased, so that was causing the tidal wave to increase in its amplitude. Now similarly, because the stroke volume is increasing, more blood is being pushed into the aorta. That means the more blood has to be pushed in the opposite direction in order to keep the center of mass where it is. So the heart also gets pushed more towards the chest wall. Okay, so now when the heart gets pushed more towards the chest wall, how long it stays there depends on how long the systole is. Now because this is hyperdynamic circulation, the ventricle is contracting very vigorously, but there is no real obstruction to the outflow of the ventricle. So systole will be of normal duration. So it will still last less than 2/3 of systole, but there will be your fingers will be elevated more than up the level of the surrounding ribs. Okay, so this is what we call a hyperdynamic circulation. Now, on the other hand, if there is an LVOT, that is LV outlet tract obstruction, that obstruction with itself could delay the peak. So this would correspond with what peripheral pulse finding? Think about it. It will be the pulsus parvus et tardus. Okay, so pulsus parvus et tardus, there was a delay in the peak of the tidal wave. Similarly, there will be a delay in the peak of the ventricular push at the apex. Okay, so these two things correspond to each other, and when they occur together, they increase each other's validity as a physical examination finding. Now, what about abnormalities of size and location? So as we've discussed, fifth left intercostal space just outside of the midline, less than or equal to 2.5 centimeters. So you can have pulse that is larger in size. Okay, so this could happen because the ventricular apex is dilated. In normal situations, the apex is constituted by the left ventricle. Okay, so it is the left ventricle, but not the tip of the left ventricle, because actually during systole, the ventricle twists. So how that happens, we'll discuss in our discussion on echocardiography and left ventricular strain patterns. But when it twists, since it is like this, it twists, the anterior portion of the ventricle becomes the superior and lateral portions of the ventricle. Okay, so because of that, that is what we feel underneath our fingers while examining the apex beat. Okay, now regardless, coming back to this, so if the ventricle is dilated, the beat will be felt over an area that is larger than 2.5 centimeters square. So that happens with dilated cardiomyopathy. Okay, and see, we have an entity known as hypertrophic obstructive cardiomyopathy or hypertrophic cardiomyopathy, and you can develop outpouchings of the left ventricular apex. So if you have hypertrophic cardiomyopathy, parts of the ventricular apex may be more hypertrophied than others. So they may also be palpable. So you may get multiple pulsations. Similarly, when you have a left ventricular aneurysm or an outpouching, that also can be felt as a separate entity. So you end up getting a double apical impulse. There are reports of triple apical impulses also in HCM. Okay. Now coming to the last topic for this video, that is the jugular venous pulsation. So the jugular venous pulse is actually the height of the blood column in the internal jugular vein. I am not going to go into the details of how to measure it, because actually that is part of the core curriculum of every medical school in the world, and you can just Google it, you can find it anywhere. We need to understand the actual physical mechanisms behind the jugular venous pulse. Just as a quick rapid assessment, it is the height of the fluid column above the level of the clavicle in the internal jugular, not the external jugular. Okay, and it is better seen than felt because it is a venous pulsation. So the meniscus is actually what you see moving up and down, and usually to see it in a normal person, the person has to be at least at 45 degrees. So we start it by keeping the patient's chest wall at 45 degrees to the horizontal, and if it is not visible, then we make the patient go down and down till the time the patient is almost horizontal, If it is visible but it is above, the top cannot be seen, then what we do is we make the patient sit up a little bit more so that the vector of gravity is more in line with the fluid column and it gets pulled down a little bit more and we can see the top of the column. Now we can use that to estimate the central venous pressure, but we don't do that anymore. Okay, that is a outdated thing to do. What is more important is actually the pulse waveform that you see. So we need to understand how that waveform comes about and the abnormalities that can arise from it. So we'll be discussing the normal JVP. There are two abnormalities that need to be understood clearly. One is a large A wave with a decreased Y descent. We'll discuss what these waves are. And the second is a large B wave with a rapid Y descent. The last thing that we'll be discussing is two eponymous signs, that is our abdominal jugular reflex and our Kussmaul sign. So we'll be discussing the mechanisms. So coming to the normal JVP. Now, to understand the normal JVP, we need to understand the changes in pressure during the cardiac cycle. So this is the cardiac cycle, okay, as represented using a pressure versus volume curve. Now, the pressure versus volume curve is a very useful way of representing the changes in pressure during the cardiac cycle, because there are discrete, clear and repeated changes in pressure and volume during the different phases of the cardiac cycle. So we'll just go through that, and I have also shown the changes in left ventricular pressure as diagrams around the pressure volume curve to give you a more intuitive understanding of what is happening. Now, I have purposefully inverted the four-chambered view of the ventricle, because this is what you see when you do echocardiography, and when we go in the next video into echocardiography, I want you to have that understanding. Okay, so this is the right ventricle, this is the left ventricle, this is the right atrium, this is the left atrium. Okay, so I hope that much is clear, and I have color coded the diagram such that a green represents increased pressure inside the left ventricle and yellow represents decreased pressure. And the deeper the green, the more is the pressure, the fainter the yellow, the less is the pressure. Okay, fine. So we start our story with the beginning of the cardiac cycle in diastole. Okay, so where does diastole start? Diastole starts here. Okay, so during the beginning of diastole, what happens is the ventricle has finished contracting, so now it is dilating. Because it is dilating, a negative pressure is developing within the ventricle. Okay, so that has been shown as I've said, decrease in blood pressure is yellow, so that has been shown as a yellowing of the ventricular lumen. So as diastole, because there is a negative pressure there and the pressure within the left atrium is essentially zero, there is a pulling of the blood into the left ventricle. This is very important. Here the blood is being pulled. Under normal physiological conditions, it is the blood is being pulled into the left ventricle during early diastole. So this is known as early rapid ventricular filling. Now eventually the pressures between the two chambers equalize, because blood is moving into the left ventricle and occupies that vacuum that has been produced. So as a result, the flow rates become flattened. So the curve becomes flattened. So that is called diastasis. Then after that, at the end of diastole, atrial systole happens. So the atria contract. Okay, so that produces what is known as the atrial contraction or the atrial kick. Okay, so these are the three separate parts of diastole, and as you can see, they represent the bottommost part of the pressure volume curve. So this pressure here, this volume here is the LV, initial diastolic volume, and this represents the LV end diastolic volume. Okay, so I hope you're getting a intuitive understanding here. Now, importantly, this would then represent the opening of the AV valve. Okay, this is the opening of the AV valve. Now, this would represent the closure of the AV valve. AV valve as in the mitral valve in this situation. Okay, so once the AV valve closes, what we have is the ventricle is contracting. So as you can see, the ventricular pressure is becoming green. It becomes progressively green, and the pressure within the ventricle increases and increases. But see, when pressure is not enough to, it doesn't exceed the pressure within the aorta. So the aortic pressure is still higher. Okay. So because of that, the aortic valve doesn't open. So during this phase, the pressure within the ventricle increases. So the curve goes from here till here, but the volume doesn't change. Okay. So this is known as isovolumic contraction. Okay. Eventually a state is reached where the aortic valve opens. And this opening of the aortic valve initiates ejection. So the blood moves into the aorta. Okay. So now what happens is the blood is moving out of the ventricle. So the volume of the ventricle falls. The pressure increases to a peak, and then the volume falls. Okay. So this is your systole. Now after systole, what happens is the ventricle is now relaxing. So the positive pressure start to fall down. They fall down, and then eventually they fall down so much that the mitral valve can open up again. They have fallen below the pressure of the left atrium, which is 0. So they fall into 0. Okay. So this is your cardiac sector, and this is how it is represented on a pressure volume curve. Now I know this is a little complicated to wrap your head around, and many of the things we've discussed are quite complicated, but a deep intuitive understanding of this curve is very important. So before we go ahead, I would suggest you make sure that you are very clear about what is happening here. Okay. Lastly, the red arrows here show the direction of blood flow, and the purple arrows show the direction of the vector of contraction of the ventricle. Okay. So this pressure volume relationship can be extrapolated to various parts of the JVP. So as you can see in this diagram, the V wave of the JVP, the ascent of the V wave corresponds to the late part of the isovolumic relaxation phase. Okay, the early rapid filling part corresponds to the early rapid filling of the right ventricle. So that happens after the opening of the AV valve or the tricuspid valve. So the tricuspid valve opens around here, and then after that the right atrium decompresses while the right ventricle is dilating. As a result of that, there is negative pressure within the right ventricle, and as we've discussed previously, it is the negative pressure caused by normal ventricular relaxation that is the driving force that causes blood to move from the right atrium to the right ventricle, or either atrium to the respective ventricle. Okay. Then once diastasis is reached, the flow essentially normalizes and we reach this lowermost point, and then atrial contraction corresponds to the A wave. Now after the atrial contraction, what happens is that the ventricle starts to contract. So once the ventricle starts to contract, that corresponds to your isovolumic contraction. So this is where the AV valve closes. Okay, so this was where the AV valve was opening. Okay, and after that, once the AV valve closes, then there is the isovolumic contraction. So that corresponds to your C wave. And once the ejection starts, there is the ventricle becomes smaller in size. So as a result, the annulus is pulled down. The tricuspid valve annulus is pulled down. So that results in further decrease in the pressure within the right atrium because it is being pulled. It is being pulled apart. So the volume of the right atrium is increasing. Now, therefore, the X descent depends on two parameters. The X descent initially depends on atrial relaxation, and after the AV valve closes, the X descent actually depends on ventricular contraction. Why? Because the ventricular contraction is what is pulling down the tricuspid valve annulus. Okay. So let's talk about the first abnormality, that is a large A wave with decreased Y descent. Okay. So this is what is happening. There are two abnormalities here. the first thing is we've got ventricular ischemia. Now, when you have ventricular ischemia, one must remember that at a molecular level, both any type of muscle fiber, both its contraction and its relaxation are active processes. They require ATP. So, because they require ATP even to relax, if there is myocardial ischemia, the relaxation cannot happen. So, because relaxation cannot happen, volume cannot increase. If volume cannot increase, pressure cannot decrease. So during your isovolumic relaxation phase of ventricular relaxation, okay. So during your isovolumic relaxation phase of ventricular relaxation, what we find is that the pressure is not falling fast enough. Okay. So why is that? Because the blood is not moving from the right atrium into the right ventricle. Okay. Now, if that blood doesn't move from the right atrium into the right ventricle, it will keep sitting in the right atrium. So eventually, when the atrial systole starts, that is the end of ventricular diastole, there is atrial contraction. At that point, the atrium has to contract harder than it normally would, and that would result in an increased A wave. And as we've already discussed, this filling of the from the right atrium to the right ventricle is what represents your Y descent. So there will be a decreased Y descent and there will be an increased A wave. Decreased Y with increased A wave. Okay. Now similarly, say there is no ischemia. It's just that the myocardium is very thick. Now because it is very thick, its compliance is less. That means that the change in volume per change in pressure is a little bit less. Okay. So such a myocardium, a hypertrophic myocardium, cannot relax enough to accommodate blood during diastole. So what happens is that the pressures just don't fall. They remain above normal throughout diastole. So all of that blood that was supposed to go into the right ventricle, okay, is still sitting in the right atrium. Again, the A wave will increase, and because there was no filling of the right ventricle, there will be decreased Y descent. So there will be a decreased Y descent and there will be a increased A wave on your jugular venous pulse. Okay, so these are the two abnormalities. So whenever you have a increased A wave, what happens is that the Y descent is decreased. So the V wave is no longer visible. What you see is a increased A wave. Okay, now so you get just one pulsation. Okay, and that pulsation happens during atrial contraction. So it happens during diastole. So that is how you pick it up. Okay, you get a single pulsation, a large pulsation, but a single pulsation corresponding to the ventricular diastole. So it will not be in sync with the apex beat, okay, or the carotid pulse. Now, okay, so this is what we've seen just now. In ischemia, there is a decrease in right ventricular relaxation during early diastole. That results in a decrease in the Y descent. So this is what results in the decrease in Y descent. And because there is pent up blood within the right atrium, that then needs to be contract more to push that blood into the right ventricle. So it corresponds to a large A wave. Similarly, when there is a hypertrophic cardiomyopathy or there is hypertrophy of the right ventricle due to any cause, there is decreased ventricular filling throughout the whole of diastole. That corresponds to a decrease in Y descent, and the atrium then has to contract more. That corresponds to an increase in A wave. Okay, so RV ischemia and RV hypertrophy or external pressure on the RV due to tamponade both cause an increased A wave. Now, importantly, tamponade also causes a compression of the superior vena cava, because tamponade happens because of increased pressure within the pericardial cavity. In the pericardial cavity, the part of the IVC and the SVC actually extend into the pericardial cavity. So the SVC has no pressure. It is the central venous pressure, so 0 to 5 millimeters of mercury. Any amount of fluid at pressure within the pericardial cavity will compress the SVC. So that will essentially completely stop right ventricular filling, right atrial filling. Okay, so that will result in essentially an absent Y descent. So a tamponade will actually have an absent Y descent. So it is absent. It is not even there. Okay, it is not just decrease, it is actually literally absent. Okay, now, so what could be the causes of a large A wave. So as I've discussed, they don't coincide with the apex beat because this is a diastolic phenomenon. There'll be a single wave. Okay. So the first cause would be there is just a stenosis between the left atrium and the left ventricle. So this is the most intuitive cause, that is very obvious. Now the other causes we've already discussed. There is some kind of failure of early ventricular relaxation. Okay, because there is RV ischemia, that is RVMI, or RV failure. Okay, or there is hypertrophy of the right ventricle. Okay, the other cause is there is external compression of the RV. Okay, now the external compression of the valve throughout diastole. So that would happen with cardiac tamponade. Now there is a very interesting thing that can happen because the left ventricle is so much thicker than the right ventricle. Septal thickening in the left ventricle can also take up the volume of the right ventricle. So that can prevent right ventricular relaxation. Okay, effectively behaving like right ventricular hypertrophy, although there is no right ventricular hypertrophy. So that is known as Bernheim's phenomenon. Okay. Now there is another entity known as Cannon A waves, which are actually they are very large A waves. This is even somebody who has never really seen a JVP properly will be able to see these waves. Okay, they hop up and down and correspond to your atrial contraction. So this happens when an atrium contracts against a contracting ventricle because the valve then in between is completely closed. Okay, so if the atrium contracts against a closed AV valve, all of the blood will shoot into the superior vena cava and inferior vena cava, and then into the jugular venous internal jugular vein. Okay, so now this happens. Why would the atrium and ventricle contract simultaneously? So this could happen because the stimulus for contraction is occurring at the same time. Okay, so this happens in atrioventricular nodal reentral tachycardia. Okay, so AVNRTs. This happens if the origin of the depolarization happens at the junction, that is the AV node. So those are called junctional tachycardias, and this happens when there is a accessory pathway with very rapid anterograde conduction, which results in atrial contraction and almost simultaneous ventricular contraction. Okay, so this is what we call it, and here the contraction of the ventricle and the atrium is happening regularly and at the same time. So there will be a rise, and if it is at a rate that is more than 100 beats per minute, that is, if there is tachycardia, then it has been eponymously named the frog sign. Okay. Now, on the other hand, this could also happen if there is a dissociation between the atrial contraction and ventricular contraction. Say there is a complete heart block. Okay. So in that situation, or high grade heart block, in that situation, there will be points in which the atrium contracts and the ventricle is also simultaneously contracted. There will be points when that doesn't happen. There will be points in time when that happens. So, and there will be an irregular but very large A wave. Okay, so that is another type of Cannon A wave. Actually, this is finding on JVP can actually help you differentiate between an AVNRT, okay, and heart block just by looking at the patient. So it is something that looks very cool when done on the bedside. But again, once you understand the mechanisms, there is nothing really that complicated. Okay. Now, increased V waves with rapid Y descent. Why would this happen? So this happens because, see, diastolic filling occurs, but during diastolic filling, suddenly the pressures rise very fast. Okay, this doesn't happen during initial diastole, or even if it happens during initial diastole, there is not that much of a problem. So diastolic filling is not significantly hampered, but there is an increase in the diastolic right ventricular pressure. And since in diastole, the right atrium and right ventricle are in continuity with each other, that results in an increase in the right atrial pressure also, which then results in an increase in the internal jugular pressure. Okay, because they are in direct continuation. So that means that there is an increase in the V wave. Okay, now because the V wave is increased when the AV valve opens suddenly, there is a big pressure gradient between the right atrium and the right ventricle, and that results in your rapid filling of the right ventricle, and that results in a rapid fall in the pulse here. So there is a large V wave with a rapid Y descent. The A wave is normal. Okay, or maybe slightly exaggerated. So you see two separate pulsations during diastole. Okay, and in between there is a rapid fall. So it's actually once you see it, it's very difficult to unsee it. Okay, so once you see it, I would encourage you to see a video of the same online. What would cause this kind of a problem? So this happens because of fibrosis within either the myocardial lumen, that is the myocardial wall, or outside of the myocardium. So myocardial luminal fibrosis will happen in RV fibrosis. Okay. It can also happen with endocardial fibrosis. So there is an entity known as RV endocardial fibrosis, which will come to, okay, associated with eosinophilic disorders, Loeffler syndrome and tropical endomyocardial fibrosis. And it can happen outside of the ventricle. That is what we call chronic constrictive pericarditis. Okay, so it happens with constrictive pericarditis, it happens with right ventricular fibrosis, it happens with right ventricular endomyocardial fibrosis. Okay, now another situation in which this can happen is when you have a very advanced systolic dysfunction of the ventricle. So in that situation, what happens is that the ventricle starts to dilate. When it starts to dilate by the Laplace function, the wall tension that is developed, okay, is directly proportional to the pressure within the this thing and the width of the ventricular wall divided by the radius or the internal diameter of the ventricular wall. Okay, so what does that mean? That means that when the ventricle dilates, okay, the ventricle thins and the internal diameter increases. So the wall tension that is developed within the ventricle is much more. So once the ventricle is so tense, the wall tension is so tense, if more blood comes into the ventricle, the pressures rise very fast. Okay, again, during the once the AV valve opens, okay, this will result in a pressure gradient. So there will be backup of blood into the right atrium. So this will result in a pressure gradient between the right atrium and the right ventricle, resulting in rapid filling of the ventricle. Similarly, just before the AV valve opens, the right atrial pressure will be high. So there will be a large V wave with a rapid Y descent. So these are the entities that cause a large V wave with rapid Y descent. Okay. So again, diagrammatically, I have represented it. As you can see here, ventricular filling is normal, it is happening. Okay, it's just that the pressures have slightly increased. Okay, so that results in a large V wave. Now see, the initial parts of V wave actually correspond to isovolumic relaxation. Okay, so that is what results in a large V wave. Okay, and then what happens is, as the large V wave as the atrioventricular valve, that is the tricuspidal valve, opens, this high pressure in the right atrium pushes blood rapidly into the right ventricle, resulting in sudden decompression of the right atrium, resulting in a rapid fall here. Okay, so that is what we call our large V wave with rapid Y descent. Okay, and as you can see, the A wave essentially is normal. The same thing happens when there is a right ventricular failure also. Now there is an important thing I want you to understand right now only. It will become even more relevant when we discuss echocardiographic findings. As you can see, there is a line here which I have ignored as of now, up till now. So what is that line? That is actually the change in pressure, because this is the pressure axis, versus the divided by the change in volume. Okay, which is what technically is known as elastance, or is the inverse of compliance. Okay, 1 by compliance. Okay, now at the end of systole, the relationship between ventricular pressure and ventricular volume is actually a marker of ventricular contractility, because if the ventricle can contract very fast, then by the end of systole, this curve would have reached here. Okay, so then the curve becomes straighter or shifts leftwards and upwards. Okay, and if ventricular contraction is weak, then it cannot push out that much blood during systole, so the curve actually falls down towards the right and downwards. Okay, so this is a very useful curve to assess ventricular, to represent ventricular contraction on volume pressure curves. Now as you can see, because of that, the end systolic volume that has been ejected is slightly low. So the end during the the end systolic volume is low, is higher than normal, and therefore once blood comes into the ventricle, into the right ventricle, the end diastolic volume is also increased. Okay, and that is what is actually pushing your already thinned, stretched myocardium to its mechanical limit. Okay, and essentially it starts behaving like it is fibrosed mechanically. It starts behaving like this. Actually, at a microstructural level, there is interstitial fibrosis. We'll come to that at a later rate. But this is how both of these entities behave. Obviously, in this situation, ventricular contraction is normal, so this curve doesn't shift down. It is normal. Okay. Whereas in the dilated cardiomyopathy situation, there is a shift of the elastance curve, or the contractility, what represents contractility of the right ventricle, downwards and towards the right. Okay, so as we've just discussed, you get a large V wave with rapid Y descent in RV and or pericardial fibrosis, also endomyocardial fibrosis. Okay, which can also, by the way, happen with carcinoid syndrome. And you get it when you have increased RV and diastolic volume, which happens with dilated cardiomyopathy. Okay. Now, lastly, we have some abnormalities of X descent. X descent, as we've seen, essentially initially represents atrial dilatation, and then after the C wave, it represents ventricular relaxation. Okay. Okay. So, it represents. Okay, so initially it represents atrial dilatation, and then it represents, after the C wave, it represents ventricular contraction pulling down the tricuspid annulus towards the apex of the heart. Okay, as a result, stretching the right atrium and decreasing the pressure within the right atrium. Okay, right. Now, so we can have a decrease in this if the right atrial pressure just doesn't decrease. Even though the annulus is being pulled down, the right atrial pressure is not decreased, because there is something within the lumen of the right atrium. So what is that? That could be blood, it could be a clot, it could be a tumor. So it could be tricuspid regurgitation, it could be atrial fibrillation resulting in a clot formation within the right atrium, it could be an atrial myxoma. Okay, and there could also be a failure of ventricular contraction. So the AV valve is not pulled down only. So that happens with RV failure. Okay, very clear. Now, whenever there is exaggerated right ventricular contraction, which we've just seen, whenever there is a decrease in right ventricular filling, in order to maintain the stroke volume, more of the blood needs to be ejected, a larger fraction of needs to be injected. So in all of those entities where we had a large V wave with the rapid Y descent, there is also a exaggerated X descent. Okay, but again, those are difficult to quantitate, when you're looking at the isoform clinically. But if asked, these are the causes, and I hope that the mechanisms are clear. And there are two eponymous signs before we end. Now, one is what is known as the abdominojugular reflex. Okay, so as we've just discussed, at the beginning of ventricular ventricular filling, the ventricle is relaxing, and in a normal person, that relaxation is what produces a negative pressure within the right ventricle and pulls blood into the right ventricle. There is no component of increased right atrial pressure there. Okay, so what we do is we try to see if the ventricle can handle a little bit more volume. Okay, so we press on the right upper quadrant of the abdomen, that is on the liver. Okay, for 10 seconds. Okay, it is said you should apply 40 millimeters of mercury of pressure, but obviously it's a firm pressure applied for about 10 seconds. Okay, now after that, what happens is the venous return into the right side of the heart increases. Okay, now how much blood is being pushed in? Around 30 ml. Okay, so that 30 ml of blood, normally when the right ventricle relaxes, its volume increases by about 15 ml. So there will be a normal rise in the because another 15 ml is left, so that blood would go into the internal jugular vein. So there would be a slight rise, but this rise the ventricle should be able to compensate for, because when there is an increase in ventricular volume, there will also be an increase in ventricular contractility. Okay, so over subsequent cardiac cycles, the right ventricle will be able to push this blood into the pulmonary circulation. Okay, so as a result, usually within 15 seconds, the jugular venous pulse will fall by more than 3 centimeters. Okay, in spite of persistent pressure being applied. Now, if there is a right ventricular systolic dysfunction. Okay, the dilatation of the ventricle doesn't result in increased right ventricular contraction, so some blood will still remain. So it will take longer than 15 seconds for the JVP to fall back to its normal height. So this is what is known as the abdominal jugular reflex. Now, unlike whatever we have discussed as of now, all of the large A wave with decreased Y descent and the large V wave with rapid Y descent, the abnormalities of X descent, this is not representative of right ventricular diastolic dysfunction. Okay, it is a finding that represents right ventricle systolic dysfunction. Okay, I hope that much is clear. So this is the only JVP find that is a finding that represents right ventricular systolic dysfunction. Okay, now the next sign, and this is a very important sign, okay, that we need to discuss, is what we call Kussmaul sign. Okay, so during deep inspiration, a similar thing happens as applying pressure on the right upper quadrant of the abdomen, but there is a slight difference. Inspiration causes around 15 ml of blood extra to enter into the right ventricle, and normal right ventricle, just through its normal relaxation during early diastole, should be able to accommodate this. Okay, so basically, if this doesn't happen, that is the JVP doesn't fall. So when the right ventricle is dilating, the JVP doesn't fall. That is, the Y descent is not the JVP instead rises. That there is not a Y descent, rather the JVP rises while during inspiration. That indicates that there is a problem with right ventricular relaxation. And when is there a problem in right ventricular relaxation? During early diastole. Okay, so this would correspond to causes of increased V wave plus rapid Y descent, to increased Y descent. Okay, so these are exactly the same causes that I enumerated there. So if that doesn't make sense to you, please go back into my explanation of what causes a large V wave with rapid Y descent. Then it will become clear. Okay, so these are the entities in which you get Kussmaul sign. Kussmaul sign can also actually occur in entities with a large A wave but decreased Y descent, but because there is a problem with the entire filling during diastole. Okay, so however, that is less common. Okay, so it is not as common as in entities where there is an increased V wave with rapid Y descent. Okay, so that is why classically K goes for C. So K is Kussmaul sign with chronic constrictive pericarditis. And if chronic constrictive pericarditis is pericardial fibrosis, so right ventricular fibrosis would also have the same thing, and RV cardiomyopathy would also have the same thing, and right ventricular endomyocardial fibrosis would also have the same problem. Okay, fine. And similarly, something occupying the right atrium and increasing its pressure there would also have the same. So that is your Kussmaul sign. So that brings us very neatly to the end of the first part of our discussion on cardiac physical examination. As I've discussed, in the next video, I will be discussing the S1 through S4 cardiac heart sounds rather, and I will also be discussing added sounds. I will not discuss murmurs as of now because they warrant their own discussion, and our discussion on murmurs is better suited in a case where there is prominent palpitation, volumogenic palpitations. So I'll discuss it in that series. Now, thank you, and I'll see you in the next video.